The road to discovery of renin-angiotensin system began in 1898 with studies made by Tigerstedt and Bergman, who reported the pressure effect of renal extracts, which they named renin based on its origin. And in the 1930s to 50s, angiotensin was discovered independently in Buenos Aires and Indianapolis as angiotensin and hypertensin. In 1958, it was named as angiotensin. We welcome onto the stage Dr. SUNIL Anthony, Assistant Professor of Medicine, BIBY Medical College, Thiruvalla, and Dr. Abdullah TG, Consultant Interventional Cardiologist, Travancore Medical College, Kollam, to chair our next session by Dr. JABIR ABDULLAKUTTY, Paradigm Shifts in Managing Failing Heart.
Good afternoon. At the outset, we thank the organizers, the PADMA Foundation, for giving us an opportunity to chair the session on paradigm shift in the management of heart failure. As we all know, the heart failure is a common presentation of heart disease, but the assessment and treatment of it are challenging to the treating physicians. So we have various classes of drugs are there and being used to treat heart failure. Still mortality remains high. In this juncture, our speaker, Dr. JABIR, presenting to us about a new molecule, and we hope that the novel molecule will usher a new era in the treatment of heart failure. And without further ado, we welcome Dr. JABIR to enlighten us on how this new molecule is expected to bring a paradigm shift in the management of heart failure. Over to Dr. JABIR.
Thank you, chairpersons, seniors, and my dear friends. So we have been moving from the problems of diabetes, or rather the management of diabetes in terms of diabetes per se, to another field which is a most important problem of diabetes. If you look at heart failure, this is the most problem, or rather I must say the most fatal potential problem of any diabetic patients. If you look at across the entire heart failure patients, 50% of at least 50% will be diabetes. So there is a close link between diabetes and heart failure. And I'll be talking about something new that has happened in the field of heart failure. If you go back to 1933, this was the essence of medicine, because it's everything for any cardiovascular disease. The final outgoing pathway is cardiac failure. So in the cardiovascular continuum, all the risk factors, they converge into a disease point, and the disease progression ends up in heart failure, and the patient exits. So the very essence of cardiovascular practice in the early detection is the early detection of heart failure, which was commended in 1933, is still hold good. I'll take your attention to a case, a 50-year-old male who had an anterior STEMI, now with dyspnea of exertion class 3, type 2 diabetes of 8-year duration, hypertension 4 years. Right now, when I saw this patient, his heart rate was 90 per minute with a blood pressure of 148 over 90 millimeters of mercury with an elevated JVP, and cardiomegaly with a short first heart sound and a third heart sound. The X-ray shows cardiomegaly with pulmonary venous congestion, and this is the echocardiogram. I think you can make out the echocardiogram. The heart barely moves. You can see here the heart barely moves, the ejection fraction close to 20%. And this person was started on torsemide, aldactone, bisoprolol, enalapril, and digoxin. And after a month's time, we could improve the therapy to enalapril of 20 milligram per day, which is the usual target. Can use up to 40 milligram per day. A bisoprolol of 5 milligram per day with a heart rate of 78 and a blood pressure of 106 over 84 millimeters of mercury. 20 milligram of diuretic, digitalis, aldactone, aspirin, and clopidogrel, a large array of all the current evidence-based management of heart failure. Right now, he is still in class 3 symptoms, 2 admissions with heart failure exacerbation, and which was treated with IV diuretics. Now, what else is there in the medical therapy? That is what I am going to discuss. So heart failure, especially this heart failure with reduced ejection fraction, the contractility of the heart is coming down, which seems to be the most progressive problem. It is a progressive problem, potentially fatal, with significant morbidity and mortality. And we currently face as a heart failure epidemic. Large number of patients, what the current statistics says, are all underestimated prevalence of heart failure across the community because of the underreported cases. And if you look at the mortality of the heart failure across the globe remains almost the same. in the Indian studies, the inter-heart failure, the Indian data from the inter-heart failure, they found that the mortality is almost close to 25 to 30%. In the 1 year mortality is almost 26%, which was more in the acute heart failure rather than in the chronic heart failure. Our own data from the Trivandrum Heart Failure Registry, they found an in-hospital mortality of around 7%, a 1 month mortality of 13%, and one of the 3 dies in a year, and at the end of 3 years, only 1 in half, only 1 in 2 is surviving. So it is a potentially fatal disease, great morbidity, and a very high mortality. So what is our aim in treating the heart failure? The aim in treating the heart failure is to keep his life long, and not only keep his life long as a misery, but keep his life long with a better quality of life. So less hospitalization, longer period of life, better feeling with normal activities is the ultimate aim of treatment of every condition for that matter. So if you look across the timeline of treatment of reduction in mortality and morbidity with pharmacological therapy and other therapies in heart failure, we introduced the ACE inhibitors long way back in 1987. So towards the later part of the 90s, the consensus study and the SALT trial and ACE inhibitor became a guideline recommended treatment. Beta blockers a little afterwards in 1996 and towards the later part of the 1990. Then the mineralocorticoid receptor antagonist also towards the early part, or rather the latest part of the 1990s. So with the current millennium, or we started using the devices like the CRT devices, the ICD devices with the data from these trials. And of late, even after the introduction of this, a new drug has come, which is in the 2014, that is the ARNI, which I'll be discussing. So till 2014, we have been dealing with the maladaptive responses like an increase in the sympathetic activity, increase in the renin-angiotensin-aldosterone system, which initially supports the heart, but later on becomes counterproductive. And this was countered by inhibiting these responses, the maladaptive responses. Now the concept is changing. We are going to boost up an adaptive response, which is the natriuretic peptides. The metabolism of natriuretic peptide is going to be inhibited by using a neprilysin inhibition. That is the drug ARNI. The other things in the armamentarium is the ivabradine hydrolysine nitrate combination, digitalis, intravenous iron, and of course SGLT2 inhibitors in diabetic patients to prevent heart failure. So this is the entire gamut of pharmacological therapy and device therapies for heart failure. And ACE inhibitors, beta blockers, and mineralocorticoid receptor blockers, they are class 1 recommendations for treatment of heart failure. But if you look into the original data of these studies, you can see the enalapril, which was introduced in 1999, New England Journal of Medicine. The SALT study, the enalapril arm, at that time the best therapy, enalapril arm, more than 1 in 3 died. So 36% mortality. So further much improvement was required. Bisoprolol, the bisoprolol study of the beta blocker study, there also in the bisoprolol arm, the 12% was mortality. The mineralocorticoid receptor antagonist, the eplerenone, you can see the primary endpoint is still to the tune of 20 to 25, almost up to 20%. So despite these medications, a significant morbidity and mortality persists in this group of patients, so which warranted a further improvement in the outcome. So this is the pathophysiology. The sympathetic nervous system, the renin-angiotensin-aldosterone system. What they produce is it increases the heart rate, it increases the stroke volume, it maintains the cardiac output for some period of time. But later on, this becomes counterproductive because of its problems of vasoconstriction. It promotes fibrosis because of the underlying pathophysiology, promote fibrosis, apoptosis, further cell death, cardiac hypertrophy, sodium water retention, and the florid heart failure. So we try to inhibit these two systems, and we obtain benefit. The next group is the natriuretic peptide, which acts exactly opposite. The effects are exactly opposite to that of the sympathetic nervous system and the RAAS system. It produces vasodilatation, it produces diuresis, it produces natriuresis, it decreases the sympathetic tone, it decreases the cardiac fibrosis, it may even reduces the cell death. So the exactly opposite problems, the beneficial effects are produced by this natriuretic peptide system. So if you improve the natriuretic peptide system or maintain a high level of natriuretic peptide system activity, it's going to be beneficial in heart failure. So in what way you can do is by inhibiting the metabolism of natriuretic peptides. It's not only natriuretic peptides, a large number of molecules like adrenomedulin, substance P, angiotensin and bradykinin, all these things are metabolized by neprilysin. So you inhibit the neprilysin, and when the neprilysin is inhibited, there can be an increase in the natriuretic peptides, along with the other things also, along with there is an increase in the level of bradykinin and other substances. So there is one more problem. So when you use a neprilysin inhibitor, neprilysin is involved in the metabolism of angiotensin 1, in the metabolism of angiotensin 2. So when you inhibit neprilysin, there is a problem. It increases the level of angiotensin also. So the paradigm shift is this thing. From the neurohormonal inhibition of antisympathetic activity, anti-RAAS inhibitors, we are moving on to an era of neurohormonal modulation, where we are using a molecule which produces vasodilatation, which produces natriuresis, which has got antimitotic effects. So combining these drugs, we are going to have better treatment. So they tried initially neprilysin inhibition alone. It was not useful because of the heightened activity of the angiotensin. Then combined with ACE inhibitors, but it was fatal because of the unacceptable increase in the level of angioedema, incidence of angioedema. So currently, the drug is used as a combination of neprilysin inhibition with angiotensin receptor blockade, and this helps to bring neprilysin from oblivion to the center stage. So this is the study, the paradigm heart failure study, which is the largest ever clinical trial in heart failure of 10,000 patients screened, but almost 13% of patients were removed, and 8,000 plus patients were trialed. Basically, New York Heart Association class 2 patients, class 3 patients, which comprises around 94% of the patients, mostly class 2 patients, 70%. LV ejection fraction less than 40%, later on amended to be less than 35% with an elevated BNB. And those patients who had a use of ACE inhibitor or ARB, but able to tolerate stable dose equivalent to at least enalapril 10 milligram daily for at least 4 weeks. I'll come to that. That was this catch of this study. This is a study which is wonderfully designed, because all the patients were first tried with enalapril, and then with a washout period tried with the investigational product to see whether they really tolerate these drugs. Only those patients who could tolerate the standard dose of these drugs were then randomized into 2 groups, the Sacubitril valsartan group and the enalapril group. The doses they tried to achieve is 200 milligram twice a day of Sacubitril valsartan and 10 milligram twice a day of enalapril. And this study was prematurely discontinued because of the overwhelming benefits. This is the benefit. The benefit, most important thing is the benefit started quite early, with a very high statistical significance, which the number needed to treat over 27 months was only 21, and there is a 20% reduction in the endpoints, basically death and heart failure hospitalization. All the deaths, all-cause mortality, cardiovascular death, sudden death, death from worsening heart failure, the entire group of deaths were reduced with this drug. And that was regardless of whether the patient had, 15% of the patients were put on ICD. So whether an ICD was present or not did not change the endpoint of the study. The benefit of the drug was there despite whether a ICD was present or not. Hospitalization of heart failure was significantly influenced. The heart failure first hospitalization was reduced, the total number of hospitalization reduced, and the readmissions or after each hospitalization was reduced by this drug. And that is the cumulative number of hospitalization per 100 patients, because once a patient with heart failure was hospitalized, that B gets further hospitalization. This patient is destined to have further more hospitalization. So the total number of hospitalizations were reduced. The first hospitalization, you can see the beauty of this drug. The drug started acting within 10 days. Even by 5 days, it started producing its benefit. It started separating the curves. That means the drug at a short period of time produced a significant benefit of reduction in the heart failure. So what it finally produced is an additional 20% benefit to that benefit which was already there with the use of ACE inhibition. So in fact, if you extrapolate this data, this is basically a RAAS, this is also a RAAS inhibition. This particular RAAS inhibition produces almost a 40% relative risk reduction in the endpoint which was studied. And this was in the background of the standard medical therapy available, the evidence-based medical therapy, 93% penetration of beta blocker, 80% diuretics, half of mineralocorticoid receptor blockers. It's only 56%, but that is the current world standard. Digitalis, 15% ICD, and revascularization in 1/3. So with the background of the current the guideline recommended therapy, this produces significant additional benefit. And the benefit, as I said, appears quite early. So 21 patients to be treated to prevent a death or a hospitalization over 27 months, and to prevent a death due to cardiovascular disease, it was 32 patients to be treated over 27 months, and to prevent the first hospitalization and for worsening of heart failure, it is 36 patients. But of course, there are concerns. What is the tolerability of this drug? What is the long-term safety of this drug? And what is the cost effectiveness? The problems found was a symptomatic hypotension in 14%, a significant amount of impaired renal function, 5%, hyperkalemia in 12%, and angioedema in 0.5%. But if you really look into the data, we can see that the adverse effects were more in the enalaprilam rather than in the drug arm, that is the Sacubitril valsartan combination. The side effect which was more and which led to a discontinuation of the drug because of the adverse effect was basically hypotension, but the drug discontinuation was only in less than 1%. To be precise, it is 0.9%. Then the question, is it for all patients admitted with heart failure? Is it for the entire group of patients with heart failure? Because paradigm heart failure trial did not enroll patients with hospitalized heart failure, acute heart failure with preserved ejection fraction, post-MI acute, or acute immediate post-MI period of heart failure. So these 4 groups were not represented. They were all stable patients on standard medications, walking around patients with class 2, class 3 symptoms. So some amount of data generated afterwards, I'll not go into the details of this study, the transition study, they looked at only one thing. Can the patient with acute heart failure tolerate, hospitalized patient, tolerate the drug Sacubitril valsartan to its and titration to its target dose? Of course they could. They found at least 50% of the patients of such groups with heart failure and reduced ejection fractions stabilized after an acute event. They could achieve a recommended dose of 200 milligram BD at 10 weeks. And those patients with fewer comorbidities, those patients who had a higher systolic blood pressure and a newly diagnosed heart failure, these are the group of patients who can tolerate this drug in the acute heart failure setup. Can we use it in the acute decompensated heart failure? A data set of less than 1,000 patients. Primary endpoint they looked at is the percentage of the NT-proBNP change, a 30% greater reduction with the use of Sacubitril valsartan. Most important thing is this drug could be tried in acute heart failure. And this drug, in the secondary endpoint analysis, they found that there was a reduction in the further hospitalization. Clinical endpoint, though it was basically not powered to look at this thing. So this is a class 1 recommendation. ARNI is a class 1 recommendation in the ACCAH, Heart Failure Society of America recommendation. So in patients with a chronic symptomatic heart failure with a reduced ejection fraction, class 2, class 3 symptoms, already on ACE inhibitor and ARB, replacement to an ARNI is warranted to improve the further outcome. A little bit conservative, the Europeans, they say that if the patient is on ACE inhibitor, mineralocorticoid receptor blocker, and beta blocker, still symptomatic with an ejection fraction of less than 35%, try to shift the ARNI to get a benefit. So when you want to prescribe an ARNI, the prescription guidance, the current indication is heart failure with reduced ejection fraction, basically a chronic heart failure patient who are stable. Dosage, you start with 50 plus 50, that is 100 milligram twice a day, and you can double the dose if the patient tolerates after 2 to 4 weeks. For those patients with a renal impairment or a hepatic impairment, or those patients who are ACE inhibitor or ARB naive may start at the lowest dose, that is 50 milligram twice a day. And EGFR of less than 30, the drug has not been tried. And when you shift from ACE inhibitor to this drug, stop the ACE inhibitor, start the drug after 36 hours or preferably after 2 days, 48 days. This is my data from the 2018 data, that is total heart failure admissions. You can see the number of heart failure we are dealing with. 1/3 of our admissions in the CCU is with heart failure. And the patients on ARNI, patients on various drugs used for heart failure, in our own data, can see our penetration of beta blocker is better, 90%, and this is almost in comparison with the current data, current available data in the other major heart failure registries like CHARM registry. There also the penetration is almost like this. The ARNI usage is 12%. And basically it is males, 80% males, and a large group of, majority, the chunk of the patient is between the 31 to 70 years. And less than 30 years, much less, more than 90 years, almost 0%. And the basic ejection fraction is between 30% and 40%, because it is, you can see 27, 60, almost 80% of the patient, the ejection fraction is between 20 and 40%, less than 20%, only 6%. And this 3% of more than 51, it is actually it's a retrospective analysis. These are patients whose ejection fraction improved after the therapy. No angioedema. I have never seen an angioedema with these drugs, or rather, I think you are all experienced physicians. Very rarely we see in our patients the angioedema due to an ACE inhibitor. And heart failure recurrence was around 12.8% after this patient put on ARNI, and death rate was 7%. And the dosage of ARNI, because every time when I go for a talk, people ask, can our patients really tolerate this drug, or can they tolerate this 200 milligram BD, or you are just boasting? No, 1 in 5 of a patient, it's close to 17% of the patient, it is 200 milligram BD. So we are always trying to shift the patient to the maximum recommended dose in a major study, or the guideline recommended doses. And blood pressure, you can see the blood pressure really maintains. My professor used to say, look, you treat the heart failure well, then the patient's cardiac output increases. Once their cardiac output increases, you need not worry, the blood pressure will be maintained. So very low blood pressure of less than 90, I could not find, but of course the blood pressure was hovering around 110 millimeters of mercury, around 20%. The rest of the patients, the blood pressure was well maintained. And patients on this triple therapy of ARNI, beta blocker, mineralocorticoid receptor blocker, almost 60%. And hyperkalemia in this group was 8%, but none of the patients had a hyperkalemia of potassium of more than 5.5. And drug discontinuation rate is a reality. It was in 15.4%. ARNI was discontinued because major reason was an elevated creatinine and intractable cough in 1, hypotension in 5, and the patient afterwards only realized that this drug cost them a lot, and they decided to withdraw from this drug. So the patient whom I have shown, this patient, I don't think you can see. This patient, the enalapril, he was tolerating very well. The enalapril was shifted to the sacubitril valsartan combination, and we could shift it up to 200 milligram twice a day. The patient is doing well so far. Only 2 more slides. There's one more patient, 52 years old, female, diabetic, hypertensive, class 3 symptoms, PND, heart rate 100, blood pressure 146 of 90, elevated JVP, a very high BMI of 42.4, and with a third heart sound. A significant LV systolic dysfunction of ejection fraction less than 25%. This patient was started on these medications. She was put on ARNI, and after 2 years, when I saw the patient last month, her ejection fraction is normalized. Is it due to the drugs? I'm not sure. But one thing is for sure, what to do with this patient? That is what you are going to ask. Now the patient's ejection fraction normalized, her symptoms are class 1. What to do with this drug? She is on ivabradine because of bronchial asthma. She cannot tolerate a beta blocker. Ivabradine 7.5 milligram twice a day. Later on we could add, initially started with ivabradine, later on added beta blocker. Now on Concord there is a bisoprolol 10 milligram, the standard dose of bisoprolol, and Jardiance, it is the empagliflozin 25 milligram, along with the sacubitril valsartan, the maximum dose of 200 milligram twice a day. Shall we stop this drug? Because it costs a lot. All these drugs together, all are standard indications, the current recommendations, but it costs a lot. The answer is not definite, but there is data. The data, the TREAD heart failure study, which was published this year, they looked at this withdrawal of pharmacological treatment for heart failure in patients with a recovered dilated cardiomyopathy. What they found that complete withdrawal of treatment should not usually be attempted in such patients. Future work could identify patient subgroups who have permanent recovery of myocardial infarction. So the current, I have heard a talk there, they was telling, diabetes improvement with the diet, that is a remission. It is not a cure. Just like that, the improvement in heart failure with treatment is a remission. A relapse can occur at any time. So when you be careful when you see that the patient has improved, of course there are curable diseases of heart failure. Apart from the curable diseases of heart failure, majority of them, they improve, but it is a remission. So to prevent the relapse, you need a suppression therapy. Probably the current drugs may be continued, the diuretics may be taken off. Symptomatic benefit, drugs that offer symptomatic benefit may be taken off, but the other drugs which alter the pathophysiology should stay on. So we can be reasonably confident that there is no reason to delay initiating this therapy. I'll end up with the quote from Leonardo da Vinci. I've been impressed with the urgency of doing. And not knowing is not enough, we must apply, and being willing is not enough, we must do it. Thank you for your patience.
Thank you, Jabir sir. It was a very wonderful talk, and it's a very effective molecule. And sir said that the recommendation is to start with a 50 milligram dose, but we usually start with 25 milligram. The tablet can be split into two and start with 25 milligram BD, and patient will, if tolerating, we can increase the dose. And we are running short of time. And any questions?
I start most of the time with 50 milligram. Seldom I cut it, seldom, because there are very few patients, especially in the acute heart failure setup, I may give 25 milligram rest. It is, because chronic heart failure, they mostly tolerate.
And the hypertension is a significant problem with starting patient.
Which one? We don't have a data on preserved ejection fraction. Right now, there is a trial going on known as the Paragon heart failure. It's same. The mortality is same. None of the current drugs which is effective in heart failure with reduced ejection fraction is effective in the heart failure with preserved ejection fraction. Not beta blocker, no AC inhibitor, no ARB. None of them reduces the mortality. It is basically right now the symptomatic treatment. The last trial which came is the TopCat trial using the mineralocorticoid receptor antagonist. A subgroup of patients may benefit, but by and large a negative trial.
Thank you, sir.
Definitely. Because the study has also shown that those patients who are taking even the suboptimal doses benefited. But there is no question, sir, because 50 milligram and 200 milligram, the difference is 5 rupees. So any patient who can afford a 50 milligram will not naturally afford a 200 milligram.
Thank you, sir, for that wonderful and invigorating talk, elucidating on this new treatment option and proposing a practical guide to this new drug with a strong level of recommendation in the main international guidelines. We welcome Dr. SUNIL ANTONY for presenting a token of appreciation for Dr. JABIR ABDULLAKUTTY. Thank you, sir. We welcome Dr. P.K. Benjamin, Senior Physician, Thiruvalla, for presenting a token of gratitude to Dr. SUNIL ANTONY.